Hello, friends. I'm Dr. Anupam Jena. I'm an interventional cardiologist at Kalinga Institute of Medical Sciences in Bhubaneswar, Odisha. This is for my cardiology friends, interventional cardiology friends, this presentation. And here I'll talk about a case. I'll show one case of uh, intravascular lithotripsy and followed by bifurcation stenting with the use of double kissing crush technique. Let me just show. Let me present my case and then we'll discuss about these things. Okay. So I'll present a case of left main bifurcation stenting in calcified coronaries. As we know that the spectrum of percutaneous coronary intervention is gradually widening and we are going into more and more complex cases. We are managing more complex cases. And in that context, I would like to add that left main bifurcation stenting, even in the presence of severe calcified lesions, can be done. Of course, we have to learn some tips and tricks for doing that. Okay, so we have a around 70-year-old male who is non-diabetic, hypertensive, presented with this angina, class 3 angina for 3 months. His ejection fractions were normal and there was no regional wall motion abnormality. And this is the angio. So here, angiographically, we can see that there is a severe calcium lesions with high calcium content. The distal left main is around 50%. And this is the epicranial view. And this is the aleocaudal view, where we can appreciate all this presence of calcium and presence of severe disease. However, there is one thing that needs our attention, that the distal LAD is diffusely diseased here. So it's a diffused disease. The surgeons felt that it was not a very good graftable vessel. So after discussion with the heart team and with the patient and family, we decided that we'll go ahead with the percutaneous coronary intervention in this case. And this is a true bifurcation lesion, Medina 111, where we have a left main distal 50%, ostial LAD around 70%, and ostial LCX around 90%. Disease in this case. And this is the right coronary artery. In the right coronary artery, we see that the mid portion of the RCA is around 70% disease. And the distal part of the RCA is okay. There is presence of some plaques there. So I would like to show that these are the most the IVS is not running. So these are the most calcified coronary part where we see 360-degree calcium, presence of 360-degree calcium. And there was loss of reverberation in some of these areas. That means presence of dense calcium. In the presence of dense calcium, on intravascular ultrasound, we do not find the reverberation sign. So here we have a reverberation sign. That means this is, in this area, the calcium is thin. But here we do not see a reverberation. So that means the calcium is thick in these areas. So once we have decided to go ahead with a percutaneous coronary stenting, what is the strategy that we should do? As you have seen that in left main cases, the decay crush, the double kissing crush technique has shown superior long-term results as compared to other techniques. And in this case, because of the presence of severe calcium, because of the presence of complex anatomy, lesions with high calcium, we decided to go with an upfront two-stent strategy. So naturally, the question comes whether one stent provisional stenting is okay, or you should upfront go ahead with a two-stent strategy in this case. In this case, we decided to go ahead with a two-stent strategy because you see, there is a lot of calcium, there is diffuse disease in the LCX also, and in presence of calcium, if we are going for a provisional, which later we are going for a TAP, we are converting to two-stent strategy. So technical challenges will be huge in this case, big technical challenges. So we decided that upfront we'll go ahead with the two-stent strategy. So initially we wired the LAD and LCX, then we did peridilatation with sorry. Then we did pre-dilatation with the NC balloon, and this was followed by, this is intravascular lithotripsy. So intravascular lithotripsy, basically, I think many of our cardiology friends must be aware of the intravascular lithotripsy. So in intravascular lithotripsy, we give shock waves or lithotripsy, like the lithotripsy that is used in renal stones or ureteric stones. It is the same principle, more or less. So there are emitters inside this balloon. We inflate this balloon to 4 atmosphere. Then we give pulses of shock waves, and those shock waves basically break the calcium. They produce very high local pressure in a very controlled manner so that it does not disrupt the adventitia, but it helps to break the 360 calcium. And intravascular lithotripsy is very effective to break the rigid calcium, especially if it is a 360-degree calcium. So in this case, this is the first. We did the lithotripsy in the LAD here. And then we did the most challenging thing of doing lithotripsy in the left main. So when we do lithotripsy in the left main, there are a few principles there we must be aware of, we should keep in mind. First of all, when we do lithotripsy in a non-left main location, what we do is we give lithotripsy for 10 pulses, and then we inflate the balloon to 6, and then we deflate. But in a left main location, we cannot keep the balloon inflated for a long time, because that will produce a significant myocardial ischemia. That's why in this case, in all left main lithotripsy cases, what we normally do is we give five pulses, then we go to 6, then we come down. So that there is a rapid inflation and deflation mechanism. And by that way, we can prevent unnecessary myocardial ischemia or prolonged myocardial ischemia. So in this case, we did lithotripsy in the left main, and as we see here, there is still one vest here, calcified, heavily calcified vest here. So with lithotripsy, we are finally able to break that. And then we took one high pressure NC balloon, and with that, after the inflation with the high pressure NC balloon, that vest also went. I mean, we could successfully break that vest, calcified vest. And this is after the lithotripsy. As you see that there are multiple breaks in the 360-degree calcium. As you can appreciate, all these areas, the calcium is broken, so the lesion is well prepared. And here we can appreciate all that the lesion is well prepared. Now we do not see any significant stenosis. After that, the decay cross is fairly standard, standardized stepwise procedure. So first we deployed a stent in the LAD, then we did pre-dilatation of the LCX, deployed a stent in the LCX, and this stent was crushed with an NC balloon, and did the first kissing with after the deployment of the LCX stent. Then the left main to LAD, the second stent was deployed. So this is the first stent here. This is the LCX stent, and this is the LAD to left main stent. Then serial post-dilatation of the stents were done. Final kissing balloon was done. And this is the post-stenting. IVS is not running. And we could achieve in the L6 osteum also. We don't see any. This is the IVS from the L6 osteum, so where we could achieve an MSA of 5.6, which is fairly good actually. So in the IVS for left main, for left main bifurcation, we should remember the 5, 6, 7, 8 rule. So that means the MSA of the L6 should be more than 5. In the LAD, it should be more than 6. In the bifurcation area, it should be more than 7. And for the left main, it should be more than 8. And this is the final result after the stenting. So this is areocaudal view, and this is the epicranial view. This procedure was done 2 years back. The patient is doing well. He is free of angina. The LV function is fine. So, good medical therapy and good percutaneous revascularization really helps in patients, even patients who are very difficult to revascularize otherwise. So this is an algorithm which says that lesions with high calcium content on coronary angiogram, what we should, how we should manage. So this is the DiMaria algorithm published in JACC intervention. If the lesion is balloon crossable, then it is, the management is a little easy. So I'll show one more case later on in another video where we'll see that how to manage a lesion with high calcium content which is balloon uncrossable. So, if it is balloon crossable, then you can go with a predilatation. In the intravascular imaging, you can do OCT, or we can do IVUS, where we see the calcium arc, the calcium length, and calcium thickness. So, if none of this is there, if the calcium is less than 180 degree, the calcium length is less than 5 millimeter, and thickness is less than 0.5, then we can go with an NC balloon, cutting or scoring balloon. And if we are able to achieve the optimal balloon expansion, then we later on go with stenting and stent optimization. If any of these high risk features are present, then rotational atherectomy, orbital atherectomy, balloon expansion, we can go with stenting. If still we do not have optimal balloon expansion, then we can go with a lithotripsy. However, in this algorithm, I find one problem, and the problem is predilatation comes before rotational atherectomy, which is usually not recommended. If we predilate, then we are likely to produce dissection. So this algorithm, I find this area a little problematic, that predilatation comes before rotational atherectomy. So that needs to be taken care of. Maybe small correction in the algorithm, and also on the familiarity of the operator, we can go ahead and do either rotational atherectomy before predilatation actually. And if it is not crossable by balloon, if it is crossable by microcatheter, then you go ahead with a microcatheter. We do a rotational atherectomy. If we are able to achieve a adequate balloon expansion, then we can go ahead with stenting. If no, then we'll go with a lithotripsy. So I have another case where it was uncrossable. So rotatripsy, that also I'll show at some point. And if it is still not crossable by microcatheter, then we can go with a laser. And laser will create enough lumen to pass the balloon, or to pass the rota, or to pass the lithotripsy. So lesions with high calcium content present a unique set of challenges, and those challenges usually need a good understanding of the lesion. So we have to understand the distribution of the calcium, the rigidity of the calcium, the thickness of the calcium, the distribution of the calcium. And accordingly, there are many strategies available to tackle calcium. So strategies can be a simple non-compliant balloon inflation, or a cutting or scoring balloon, and more advanced things like rota ablation, intravascular lithotripsy, then the rotational atherectomy, even laser also. And if all these things are done systematically and in a predictable way, then results are usually very good. Thank you. So I'll stop here. And there is, some of these complex cases actually we cannot say that these are like the beginners cases. They need a lot of understanding. And whenever you are whenever an operator is going for such complex cases, it is always advisable to take guidance, or even if to discuss with your senior colleagues, or even you can take a proctor also, because complex cases sometimes need more understanding, and more risk of complications are also there. Thank you so much.